So when we think about frontline treatment for patients with acute leukemias, particularly acute myeloid leukemia, there's several broad categories that we first think of as practitioners. And really it boils down to the patient factors as well as the disease-related factors. So the first thing we think about from a patient-related factor is whether or not the patient is, it used to be more age-based, and age certainly still plays a role in it to an extent, but whether or not the patient's really fit enough to undergo what we consider our standard frontline therapy for AML patients, which is intensive induction chemotherapy and consolidation chemotherapy, or if they're less fit or unfit and they harbor multiple medical comorbidities, and thereby we think that intensive chemotherapy has too high of a mortality risk for them. This allows us to determine whether or not we think this patient should undergo, like I mentioned, this intensive chemotherapy or more a lower intensity therapy. The next thing we think about, though, as well, is the patient's disease biology. Is this a favorable risk AML or is this an adverse risk AML? And that helps us decide what we do when we have a patient in a remission. Should this patient go for a consolidative allogeneic transplant, or should this patient proceed with maintenance therapy? Do they proceed with consolidation alone? I think we're seeing that maintenance is probably the future of AML, but that has yet to really fully be borne out. And so when we think about these things for the younger and fit patient population, our standard frontline treatments are still intensive induction and consolidation chemotherapy. Of course, here at MD Anderson, we're adding venetoclax with that safely to impart deeper responses and MRD deeper, meaning MRD negative responses. And then those patients are still being consolidated with more chemotherapy and transplantation. For the more unfit patient with newly diagnosed AML, we're using a combination of sophisticated targeted agents to try to induce remissions just as effectively and hopefully as deep as we're seeing based on MRD analysis and remission as the intensive chemotherapy group for the younger patients, but using a what we believe to be a more tolerable combination of medications to achieve that remission for those unfit or elderly patients that are not able to receive intensive chemotherapy. Some of those patients then are, as their leukemia is treated, they start to regain some more function and are doing better. Some of them actually do proceed to transplant, even though at first we thought maybe they wouldn't be able to. And some of them remain on this therapy and it's well tolerated, and they're able to continue on that for a period of time with long remissions.